Hello, and welcome to review of the cardiac system. This is primarily for the new nursing 214 students, but anyone's welcome to watch it and learn from it, be what it may. My name is Mark LaBarbera. I'm a nursing student going into 214, fourth semester right now at MCC. Also, I've had over 25 years of experience as an EMT and paramedic, 10 of which was critical care transport, ICU to ICU, and vent med. I'd encourage any of you to make similar videos to demonstrate things that you're familiar with. I'll see if that keeps popping up there. Some of the numbers on here may not match exactly with what MCC is teaching, but the basic physiology is what's important, and that's what I've made this up for. So the basic internal anatomy of the heart, you have your superior and inferior vena cava. This is where the blood comes back from the body. Deoxygenated blood comes into the right atrium, down to the right ventricle, through the tricuspid valve. It gets pushed out from the right ventricle, through the pulmonary valve, out to the lungs, through the pulmonary arteries. The blood exchanges gases in the lungs, comes back through the pulmonary veins, into the left atrium, through the mitral valve, into the left ventricle, or into the left ventricle, pressurized a lot more, and then pushed out through the aortic valve, into the aortic arch, and out into the body. The three offshoots here are the brachiocephalic, left common carotid, and the left subclavian. Those are fairly important to know, I believe. And we'll go back into more of this as we go through slides. Exterior anatomy of the heart. Again, the superior and inferior vena cava, right atrium, right ventricle, left atrium, left ventricle. Here you see the carotid arteries, both left and right, and we'll go into that a lot later towards the end of this presentation. Notable on here, and something we probably won't cover much in class, the ligamentum arteriosum. This is what's left of the ductus arteriosus from fetal circulation. After we're born, it kind of dries up and becomes this ligament that attaches the two great vessels here. This is implicated in sudden death from extreme deceleration injuries, such as falling from a height. Aircraft crash frequently has tearing of the great vessels. High impact, high speed car crashes, you'll get a tearing because this ligament is attached to both great vessels, and you bleed out almost instantaneously. The conduction system of the heart. Normally, in a healthy heart, we start with the SA node, the sinoatrial node. This gives off a electrical impulse, travels down these conduction pathways to the AV node, travels over here to the Bachmann's bundle, over to the left atrium to help that fire about the same time as the right atrium, to the AV node, down through the bundle of His, and then down to the right and left bundle branches, and ending in the Purkinje fibers, which innervate the ventricular heart muscle. Over here, I've drawn in the bundle of Kent, which is a rare accessory pathway, but it's important if it is patent. And what this is sometimes is an extra pathway that occasionally people will be born with. And the problem with it is that if it is retrograde, where normally all these pathways conduct only one direction, downward, bundle of Kent may conduct retrograde, which means you have a sinoatrial node, you have the SA node fire, go down through the AV node, bundle branches, hit the bundle of Kent. If this is patent and anterograde, the conduction will go back up to the right atrium and then kind of circle around and do this continuous circle. This will kind of look like kind of SVT or VTAC on your EKG, and can be quite serious. This is what would be known as WPW, or Wolff-Parkinson-White syndrome. This is corrected with RF ablation, where they put a small probe in to the heart in about this area and conduct some RF energy through it, and it'll kind of burn out this node usually, and then it's corrected, hopefully. Pressures within the heart. So this is the superior and inferior vena cava. Blood just pours back in to the right atrium, and you're looking at pressures between about 0 and 8 millimeters of mercury, fairly low. There's a contraction. The atriums contract, push blood down to the right ventricle. Here it pressurizes a little bit more. When it pressurizes, it's 15 to 30 going out into the lungs. The diastolic pressure when the right ventricle is relaxed has to be around the same range as right atrium, so it will fill. So it's 0 to 5 or so. So the 15 to 30 is fairly low pressure, but all this really needs to do is get the blood to the lungs and back, which is a pretty short trip. So it goes out through the valve to the pulmonary arteries, 15 to 30 systolic for these pressures, comes back in from the lungs at 4 to 12 millimeters of mercury, goes down to the left ventricle, and here is where you really get the pressure. This is starting to look more like what you'd see for a normal peripheral blood pressure, 90 to 140 for systolic, and 4 to 12 for diastolic. It has to be 4 to 12 because it has to fill from the left atrium. But once it gets past the aortic valve, it starts pressurizing in the aorta, the great vessel here, and it becomes between 90 and 140 for systolic and 60 and 90 for diastolic. Diastolic is important because the coronary arteries perfuse on diastole when the heart is relaxed. So there has to be decent pressure to push blood out through the coronary arteries when this blood kind of stops flowing an active forceful flow out. So while we're on the subject of pressures, this is a swanganz catheter. This is what's used to kind of monitor and look at pressures and functions of the heart. It's a fairly invasive process. The nurse wouldn't be doing this. It would probably be cardiology or somewhere in a OR suite. But this gets put in through the pulmonary vein into the heart. You have all these ports here. You have a couple injection ports, proximal, distal. You have a balloon valve. There's a balloon down here that you can inflate. There's a thermistor couple to measure temperature. There's a proximal ejection port. So just a whole bunch of possibilities here of what you're going to do with it. So this is what you use a swanganz catheter for. You can look at different pressures throughout the heart. So it gets threaded in usually through the chest, enters the right atrium. You can look at the right atrial pressure, look at the function of the heart. Important maybe if you have some dead tissue from a MI in part of the heart, you can see if there's still good compression there, if the heart's going to work, if it's not pumping efficiently enough, or this problem where you're going to have blood flow problems, maybe back to the heart, cause further MI. So it goes down through the right atrium, right ventricle, and then out into the pulmonary artery. Now, we can't get all the way through the lung with this, and we certainly can't get back into the left atrium. Um, be important to find out kind of what pressures are in the left atrium to find out what's feeding the left ventricle. But there's a problem where we can't really get a good pressure. There's not really a good way to safely monitor pressure in the left atrium, but we can approximate it. If we put the catheter up, and once we get into the smaller vessels here, we can inflate the balloon, and at the point where the balloon occludes, that's the approximate pressure of the left atrium, which is, and this is called pulmonary capillary wedge pressure. And in this picture, it depicts 6 to 12 is normal, and if you remember looking back, I think it was 4 to something, which is a good approximation. But you can also look at the pressure waves, and if you become good at reading these, this will make a lot more sense about kind of where the valves are opening and closing, and what kind of pressures you're getting, and what kind of waveforms, if this is normal or not. Well, we're on the subject of putting stuff in the heart. Implantable pacemaker and defibrillator. These typically go kind of the same way as a swanganz would, except that the whole thing is kind of buried under the skin. There's a little pocket here for the control unit. Wires go down and sense and shock portions of the heart, depending on how they're set up. The very early pacemakers had one single wire. It would kind of go down, get kind of screwed in, kind of like a fetal scalp electrode, screwed into the muscle, and it would sense and pace the hell out of the ventricle. It wasn't very efficient. The atrium may or may not be working real well, but it was better than nothing. It was better than having a person die. Throughout the years, they've made these better and better, where now they have atrial and ventricle sensing and pacing separately, so you can get a more natural atrial pace and then the ventricular pace. Some of them have dual chamber pacers, where it can get both sides at the same time, and the units are also available where if it sees a rhythm that it recognizes that it's a dangerous rhythm, it can do a defibrillation on its own. Going into the EKG, this is Enthoven's triangle. Enthoven was the one who really brought EKGs to the forefront and put them into medical use. And this is very basically the three leads that he originally used: right arm, left arm, and left leg, or leads 1, 2, and 3. So we're looking at kind of the mean vector of depolarization, the electrical movement from one side of the heart to the other. So we all know from past slides that the SA node up here fires, kind of goes down, goes this way. So this is kind of the mean vector. And what we're looking for, we can see energy either coming towards or going away from us. And if we say that we're the positive electrode, the easiest way to see stuff would be something coming towards us. If you were a police officer and running radar with a car, it would be very hard for you to be perpendicular, set out from the road, and bounce your radar gun off the car driving by and know what speed it was going, because it needs to either be coming towards you or away from you, because it's going to ping it a couple times, bounce off it a couple times, and that interval will determine how fast the car is going. Same thing with this. If you had a lead that was going directly perpendicular, and this wave of depolarization was coming exactly at that perpendicular line, you'd actually have would look like asystole. a flat line, because it wouldn't the wave would either be coming towards or going away from the positive electrode. But lead 2, this is a lead that people generally like to look at the best because it looks the best, is because this kind of mimics the normal wave of depolarization, the mean wave of depolarization through the heart from the SA node through into the ventricles. So this is a positive electrode. The energy is going this way through the heart, and we get a nice, crisp, large deflection. Sometimes the heart's turned. If there's a MI in part of the heart, if there's a big area of dead tissue down here, it doesn't conduct as well, and you may get a shift. And you can see that in the EKG, and maybe you have to change leads. Maybe you're looking at lead 3 for a better view. Maybe you end up looking at lead 1 for something. But it's an option. Here's your typical EKG. And this is very kind of stylized. But you have a P wave, and going along here, this graphic shows kind of where the impulse is, where it's going. So the P wave is usually the atrial firing. So the atrial fire, as it goes down through the AV node, kind of pauses a little bit to let all the blood from the atrium get pushed into the ventricles. You have a QRS wave, this big wave, because the ventricles are a big piece of muscle, and this is when the ventricles contract, is along where the QRS is. The Q isn't always present. In kids, you see a Q more often. In adults, especially if it's a large Q, greater than 1/3 the total height of the QRS, it's more indicative of a past MI. They'll call this the footprint of a MI sometimes, because if you have an MI where you get a Q wave, the Q wave won't go away. That's why you have a 80-year-old farmer that comes in and says, "Yep, I've felt great all my life," and you look and you have a huge Q wave. You can say, "You probably have had a MI at some point in the past, even though you didn't go to the doctor for it." So QRS, and then T wave is kind of ventricle, or the muscle repolarizing. We can think of this as kind of like dominoes being pushed down, where you set all the dominoes up and you push one down, that knocks the next one, next one, next one, and it's kind of like a wave of depolarization. This is the dominoes all being set back up. If you want to think of it that way, if that helps you at all. This is a U wave. This is some extra shifting of electrolytes, maybe. There's a lot of discussion about exactly what the U wave is, but it's an extra polarization, which I don't think we are going to go too much into. This is a 12-lead EKG, or a depiction of a 12-lead EKG. Again, this is kind of N7 triangle. Lead 3, lead 2, lead 1 goes directly across the heart. And like lead 2, you have a negative lead that it goes to. With the 12-lead EKG that takes a kind of a radial picture around the edge of the heart, you have all these positive electrodes. The computer will set this up so that the negative electrode is kind of like the whole table that the patient's on. So these are referenced to kind of a large plate that you could think of is on the back. And this is kind of like a camera, kind of taking a picture through into the heart at different angles. And you get different pieces of muscle and tissue and blood supplies as it gets kind of shot through. And this will give you a good kind of depiction of what's going on. V1 through V6 is a common setup. This takes a little bit of the right side of the heart through the septum and through the left side of the heart. There's also a right-sided EKG, and you can take these all the way around and do go right around through the back if you need to. But normally this is the one that's most commonly done. This is a typical 12-lead EKG. Don't freak out about it. What this is this is V1, V2, B3, and then AVR, AVL, AVF, which is kind of a augmentation of these, which isn't as important right now. And then these are the chest leads, which we saw in the last picture. 1, 2, 3, 4, 5, and 6, and this is just a resonance strip of this is I think this is lead 2. I think it was cut off there, but I think this is lead 2, and this is just a rhythm strip, so you can look at a running rhythm, because right up here you only have 2 or 3 complexes to look at. But this is, so if you want to look at R to R or any varying PR interval, you can with this. So this is, like I said, this is pretty typical of what a normal 12 lead would look like in the hospital. Besides pumping blood, the heart makes some peptides that are important to the body. It kind of self-regulates itself. It creates atrial natriuretic peptide or atrial natriuretic factor. This is if you get a lot of pressure, heart failure, volume overload. It produces this peptide that starts the renin-angiotensin aldosterone system, and will cause diuresis, and thereby lowering the blood volume and hopefully lowering the blood pressure. Same thing happens in the ventricles. This is brain natriuretic peptide, which is coming from the ventricles. If the ventricles are being overpressured, the body sees that as even more of a problem and goes right to vasodilation to drop the blood pressure. We measure BNP as one of our values, and when it starts rising above 100, definitely above 400, it is a sign of failure, heart failure, or CHF, and stuff like that, where it's something that needs to be treated. This is a presentation I did years ago, class I went to at Albany Medical Center, and this is kind of a neat trick. So you have the coronary arteries. I'll talk a little bit about that. Like I said, the coronary arteries perfuse on diastole, so the heart stops contracting, relaxes, the blood starts to pull back in here. This is the aortic valve. Blood flows back and then flows down into the coronary arteries. You see you have right coronary artery here, and left main, left circumflex, left anterior descending are the main normal arteries, and everyone has a little bit different arterioles depending on how old they are and what's been happening, and kind of their family history. So right coronary artery, this will affect leads 2, 3, and AVF, because that's where 2, 3, and AVF are looking, is through kind of this area. Go back, left circumflex, which kind of curves around to the back here. You'll see in 1 an AVL, because that's kind of coming through here. And then left anterior descending is this big one that kind of comes down and feeds the whole left side, front, and some of the septum and stuff. And these are all of V leads, V1 through V6. And then septum is kind of V1 and 2. Septum's down through here. A lot of times it's the left, fed from the left artery, but it can be fed from the bottom. It all depends on how your individual heart is built. So knowing that, you take your 12 lead. If you draw on it, or do a kind of a virtual drawing on it, like this, you do a hook that comes down through V6 and up through V3, you draw one that comes off the left main through V1 and V2, draw one that comes down through 1 and AVL, and then this extra one that's off to the side here, 2, 3 and AVF. This will show you which arteries cover which parts of the 12 lead. Notice this 12 lead, there's no rhythm strip at the bottom. So with this, it's an easy way to tell when you're looking at a 12 lead and trying to figure out, there's a MI going on. Where is MI? If there's involvement in 2-3 AVF, you're going to think right coronary artery. If you think if you're looking at and you have changes in V3, 5, and 6, you're looking at like a mid left anterior ascending. If you have kind of global, where you have V1 through V6, this is like a mid to high left main artery, and that's real serious. That means the whole front and side of the heart through the middle and septum is dying, and that's pretty ominous. But this gives you kind of a quick, easy kind of cheat method. Here's no depiction. The V1 through V6 lateral is 1 AVL, and 2, 3 and AVF is inferior. Thank you for watching. I hope you enjoyed it. Don't be afraid to share if you think this was a worthwhile video, and hopefully I'll do more in the future.